Tell us how you recognize and manage adrenal insufficiency associated with immune checkpoint inhibitors. There have been some isolated cases of adrenal insufficiency reported in the literature. The occurrence is less than 1% of patients that receive immune checkpoint inhibitors. The presentation may be due to primary adrenal insufficiency, which is an inflammation of the adrenals due to the checkpoint inhibitor, or it may be secondary, and that is due to pituitary dysfunction or hypophysitis. The presentation includes vague symptoms as well. That includes severe fatigue, nausea, emesis. If adrenal insufficiency is left unchecked, patients can proceed to develop a more significant case, which is adrenal crisis. And this may lead to hypotension, orthostatic hypotension, and can actually have cardiovascular collapse. So it is important to have early diagnosis. Evaluation includes elevation of ACTH and cortisol level. And with adrenal insufficiency, we'll see a high ACTH and a low cortisol level. To just confirm your diagnosis, you want to do a cortisol stimulation test, and this is typically done in the morning. So after ACTH stimulation, cortisol levels are measured at 30 minutes and 60 minutes, and confirmation would mean a level of less than 18. You will also see some electrolyte abnormalities, and this includes hyponatremia and hyperkalemia. With adrenal insufficiency, one also may develop diabetes, so blood sugar level is important to manage. Management initially with adrenal insufficiency is to hold the immune checkpoint inhibitor, do a full endocrine evaluation to assure that there are no other endocrine orders involved in this. Corticosteroid administration is the treatment of choice, and this should be done before any other hormone is replaced so that it avoids adrenal crisis. Steroid replacement for adrenal insufficiency is hydrocortisone 20 milligrams in the morning and 10 milligrams in the afternoon or evening. Or it may be substituted with prednisone, 7.5 milligrams in the morning and 10 milligrams. In addition, one is going to require fluticasone replacement, and that's 0.1 milligram every other day initially, and that is titrated to effect. Really, the goal in general is the lowest possible dose to prevent adrenal insufficiency. So doses may be titrated down when patients are stabilized. In the case of adrenal crisis, if patients are hemodynamically unstable, they may require hospitalization and fluid bolus resuscitation. Also important with adrenal insufficiency is patient education. It is likely that they are going to require lifetime replacement of hormones, so patients need to be educated on stress dosing of steroids in the case of infection and trauma. If they become acutely ill, they will no longer have that flight or flight response for adrenaline, so they may need double or triple doses of steroids for 28 to 48 hours in the case of fever or surgery, sick days, and trauma. Patients should be instructed that they should wear a medical alert bracelet at all times. As with other endocrinopathies, in most cases, once a patient is hemodynamically stable and adequate hormone replacement has been completed, immune checkpoint therapy can be re-challenged and patients can go on to successful treatment on this therapy.